risk of thrombosis is not related to the length of the catheter, but it's related to the kind of infusion that you do through it, whether it's peripherally inserted or not. So if you have a PICC which has become shorter, whose tip is subclavian, brachiocephalic, you can still use it for clear fluids, peripherally compatible, thrombosis will not occur. Sometimes it may happen that in spite of the effect of using peripherally compatible solution, the tip is in a cumbersome position. For instance, it is blocked against the wall of the vein. Okay. For instance, if you have a PICC coming from the left, who have not properly entered the superior vena cava and the tip is stuck into the lateral wall of the superior vena cava, even if you use it with peripherally compatible solution, still there will be a trauma to endothelium, which will give you thrombosis because of a mechanical trauma. You know, the endothelium responds to any kind of injury with the same way, by forming a thrombus, which is a repair tissue for the endothelium. Which means that if you have a mechanical trauma, a chemical trauma, or infective trauma, the endothelium will always do the same thing. When it's ruptured, it will start a thrombus. Well, yes, there's another issue which is related to thrombosis, the fact that if you reduce critically the residual blood flow, you will get a thrombosis. But this is not the problem where the tip is the problem of that part of the vein which is smaller if compared to the caliber, which is basically is the reason why you get thrombosis at the site of insertion. And in this regard, of course, there is confusion, as you said, between the PICC of the 20th century and the PICC of the 21st century. The PICC of the 20th century was inserted without ultrasound in veins whose caliber was unknown. On the contrary, the PICC of the 21st century are inserted by ultrasound in vein of caliber which is known, and the trajectory is known, and the possible anomalies are known, all thanks to ultrasound. And there are some meta-analyses which are badly conceived who give wrong results. The most famous is the meta-analysis, so-called meta-analysis by my friend Vinay Chopra on the Lancet, in which there was a confusion between PICC of the 20th century without ultrasound, the PICC of the 21st century with ultrasound. And it was only one of the fault of that meta-analysis, but unfortunately it was quite successful. So there is still a bad press, come si dice, una leyenda negra, por el PICC, about the PICC. So people, the less competent they are, the more believe that the PICC are associated with thrombosis, which is absolutely not true. We recently published a paper, the first name is Balsorano, which was done by a Gavset group based in Florence, in which we revised completely the meta-analysis performed by Chopra, and we came to opposite conclusion. The thrombosis is something which is related for PICCs to the technique of insertion. That's all. If you minimize the trauma, if you take care of the proper ratio between the caliber of the vein and the caliber of the catheter, if you use ultrasound or intracavitary EKG for the tip location, and you have a proper intraprocedural tip location, and last but not least, if you stabilize properly the PICC, which means to use a circulating device, transparent membranes, glue, then the risk of thrombosis will be very, very, very low. And there is no convincing evidence today that the risk of thrombosis related to a PICC is better or worse than the risk of thrombosis to a CICC. On the contrary, there is wide evidence that the femoral inserted central catheter has a higher risk of thrombosis than both the PICC and the CICC. Which means that, for instance, to use a femoral line because you are afraid of a PICC thrombosis is completely stupid. Well, the future of traditional, as much as the future of traditional midline is in the extra-hospital setting, the future of short midlines is the intra-hospital setting. And they have a clear-cut indication whenever there is a DIVA, a patient with difficulty in venous access, or when there is a patient with no difficult access, with easy access, but with a peripheral line which is meant to be inside for more than 1 week. These are the two big indications of mini midline. As with any other kind of device, it must be inserted by specifically trained personnel. So if someone tells me that they have a bad experience with mini midline or PICC port or whatever, but they leave the insertion to non-specifically trained personnel, I don't care. There's nothing I can do about it. There is no such thing as a technology which has learning inbuilt, so to speak. You always have to make a little effort to use and to adopt new technology, a new methodology, a new device, etc. Of course, the good technology makes things easier, yes. But still there must be some training. Well, it's easy to be said. First, we have realized that there is no indication whatsoever for silicone PICCs. There is really no evidence. I mean, to use silicone PICCs today is absurd. You should use not only polyurethane PICCs, but power-injected polyurethane. Okay. There is no reason for not using power-injected polyurethanes. As a matter of fact, the power injector is something which has increased the performance, which allows the PICC to be used for hemodynamic monitoring, which reduces the risk of irreversible obstruction, because all obstruction are reversible if you use power injectable PICCs. In our hospital, we stopped using urokinase and other thrombolytic drugs, only because we now can resolve practically any obstruction with hydraulic pressure. Because just the fact that when you have a power injectable PICC, you have something which is resistant to 300 psi and something, which means that you can use for unblocking the catheter even a 2 ml syringe, which makes a 200 psi, which will be forbidden if you don't use a power injectable. If you use the silicone PICCs, then you should only try to unblock with a 10 ml syringe. But the 10 ml syringe does a pressure of 50 psi. And the 2 ml syringe does a pressure which is 4 times higher, which means that you have 4 times more chance to unblock a power injectable catheter, because you can use the 2 ml syringe than you have with a standard catheter, non-power injectment, which uses the 10 ml syringe. Absolutely. It makes it a blood sampling, it makes it a hemodynamic monitoring. It is less prone to tip migration. It is less prone to dislocation. Also, when you change the dressing, it has so many advantages, and practically the cost is the same. Yes. And the other thing which has completely changed, if compared to 20 years, is that now we know that there is no role whatsoever of valved PICCs. The proximal valve, distal valve, during the last 3 decades have shown to have absolutely no advantage over the non-valve catheter. The valve catheter is only a commercial trick for selling something which is more expensive, but it has no additional advantage. As a matter of fact, many valved catheters, on the contrary, they have a higher risk of malfunction. They have a less flow by gravity or things like that. Then there are some special features which might be interesting. For instance, one feature is to have a power injectable PICC with the proximal trimming, which is also something which makes the EKG maneuver easier, makes the tunneling easier, but still there are some limitations because this technology can be applied only to 1 lumen PICCs. And then there is the interest of having PICCs treated with medications for anti-infective, antithrombotic purposes. Impregnated, yes. And impregnated or coated, which are two different techniques. There is, unfortunately, there is no evidence at this moment that there is for any kind of real effect of impregnation with silver, for instance. There is no evidence of the effect and the anti-infective effect of PICCs coated with chlorhexidine. And there is little evidence, though there is something about the coating of PICCs with antibiotics. Still, the cost effectiveness is not clear yet. Yes. And on the other aspect, antithrombotic, there is no evidence-based data yet. There are some data suggesting a possible antithrombotic effect with an impregnation by a special ceramic called Indexo, but still is not something which can be considered to be effective, and even if effective, we should discuss whether it is cost-effective or not. So, for the moment, the treated PICCs are in limbo, from which we don't know exactly who will come out or who will stay.